Welcome to another episode of Foresight TV on Friday. This is one of the episodes I've been really looking forward to. I've got an amazing guest who I'm going to introduce in just a minute, but I just want to start by saying thanks so much for watching Foresight TV. I am so glad you're joining us for this broadcast. We are committed to improving the lives of people who live and work in senior living. And so we'd love to hear from you about what you're doing to make those lives better. And I want to just tell you, we produce all kinds of great thought leadership content in addition to Foresight TV. So we've got LinkedIn posts, we've got the Foresight podcast, we've got Tech Tuesday, and particularly the most important is likely our Foresight website, where we publish new content every single day. It's all free and easy to subscribe to. There's a QR code up, and there's also a link in the chat where you can click and subscribe to our daily newsletter. I just tell you from the bottom of my heart, I appreciate your passion for our industry and the people you serve. And the other thing I want to mention is we've talked about it a little bit, but we'll have tickets up next week, but we have this brand new announced, the Foresight AI Lab, that will happen in Las Vegas the third week in January. This will be a deep dive into how you can actually use AI in your senior living organization. No high level stuff. You're going to come back with playbooks that you can put in. You're going to learn from other people's experiments that they've done with AI and their success stories and some failure stories. So I hope you will sign up. And so now let's get started. Hey guys, Steve Moran here. Karen, why don't you put us side by side, Jada? Karen, welcome so much. We first met, the only time I guess we've met was at the NIC Spring Conference. And I am just over the moon excited to talk to you. You lead the SCAN organization, which is the largest Medicare Advantage program in the nation. Is that correct?
Well, I wish we were.
Okay. Talk to me
I can say that we are the largest ISNP in California. How about that?
Great. Okay, great. And so tell us what an ISNP is. Let's just start there.
So SCAN offers a portfolio of different products in the Medicare Advantage space. We are a not-for-profit Medicare Advantage health plan. So the ISNP, which is an institutional special needs plan, and an IESNP, so an institutional equivalent special needs plan, caters specifically to members who need additional assistance. The criteria to enter is that they don't meet certain activities of daily living, which you all know that very well. So our target audience are your residents in the senior living communities. And we then have a clinical team where we've built a clinical model that partners with communities so that we can bring as much as we can bedside to care for your residents and include their caregivers and family members.
So this sounds a little bit like, and I don't know whether you may hate this analogy, it sounds a little bit like PACE in a senior living community. Is that a good
It's
analogy?
A great way to think about it. I've never sort of made that correlation, but absolutely, because your community is our members' home. And so you've got the social activities, you've got the meals and the right dietetic sort of menu. So yeah, it's a comprehensive kind of all in one place in your resident's home.
Okay, and this is a mix for you. So it would be assisted living, skilled nursing, memory care? Any one of those three settings?
Yes.
Independent living, maybe?
It could be, but we find that the residents of an independent living community don't necessarily meet the criteria for an ISNP because you have to have a deficit of at least, I believe it's 3 activities of daily living.
Okay, and so I guess the first question where do I start? So I'm going to throw you both questions, and you'll be better equipped to know how to answer it. My first question is, how do how do residents get plugged into this, and do they come through senior living communities? And the second thing related is, how do senior living communities or organizations get plugged into this?
So right now, I would say there isn't as much as there is an unmet need, right? I think that the model of an ISNP and a clinical team who can partner in communities is absolutely the magic, right? It's where I think there's deficits of what senior living communities feel like. I can't handle all of these things that are related to chronic condition management, medication management. Our team just isn't equipped. But if you find the right partner with the clinical team who doesn't have things that the senior living community staff have, which is you're interacting with these residents every day and you see things that we don't see. When we talk about data and information, there's data and information rich in communities that we could never get through a physician office, for instance, like how many clicks a day does a resident hit their I need help button? That is an important input into stratification of risk, right? There's something telling us, but we couldn't get that no matter how many times one of your residents or our members visit a primary care physician office, for instance. So just really, really see so much benefit if we can partner together in the senior living community space with a model like the ISNP or Embrace model that we've got.
So what I think I'm hearing is, I'm a senior living organization. I'm going to start at the executive director level because maybe there's somebody there who's thinking more creatively, and they're looking at their population of residents and they think, I've got 10 people who really have significant deficits and who could use more help. I'd like to be able to provide them more help, but honestly, my staff resources are limited. We have an LPN that's in maybe full-time, maybe 8 hours a day, and we could sure use extra help. That's the kind of people you're talking about?
Absolutely. Like we hear this all the time. One of the biggest challenges, I've got personal experience with my mother-in-law, who had been and resided in assisted living communities, and I see the strain on the staff. We've got a staff shortage, number one, and two, the ability to train up and to support the staff. They can't do it all themselves. And so when you do bring in this extra partnership help, that can relieve so many pain points that I think senior living communities are experiencing today.
So if I'm an operator, how do I make this happen?
So today, I think because there isn't as much knowledge of this model, we're doing a lot of the outreach to senior living communities. Like, hey, have you heard? What are some of your pain points? Can we help you? But I think if we can shout from a mountaintop this availability, then I'd love it to be a two-way sort of interaction, right? Can communities start reaching out to us to say, let's explore this further? There might be a match here, there might not. But I think the more we have the interaction and the exploration, I think the more that we'll see that there is a there.
Well, one of the things I do see, hospice, of course, is very common in assisted living. And my mom was in a small assisted living community until she passed away. She was on hospice for the whole time she was there, so 8 or 9 months. And it was good for her. It was good for the community because it provided additional resources. It was good for the family. And so it was a win-win. And so it seems as if in the industry, most communities are pretty well plugged into the hospice system. And it seems like what you're doing ought to be as equally integrated into the system. And so do they reach out to Scan directly? Do they go through insurance agents? How do they actually plug in?
Reach out to Scan directly. I think we've posted the link in the chat. And so if that's something that folks can take note of, absolutely. We'd love to hear from you. No matter if it's just, I want to learn more, to I'm absolutely interested, we'll take all inquiries.
Okay, perfect. So let's go to the next. I want to talk a little bit about sort of this bigger picture We, as an industry, we believe, and I think this is true, that there is an opportunity for medically based assisted living communities that are doing significant interventions to actually reduce the frequency of hospital admissions for residents and to shorten stays, increase length of stay in the community also, so it's good for the communities. And we believe that there's this huge opportunity to save the healthcare system hundreds of thousands, tens of thousands, hundreds of thousands, perhaps millions of dollars a year. And what I find really intriguing is the idea that somehow we might be able to get to play in that, to get some financial participation in those savings. Do you have thoughts on that?
Yes, I do. And Steve, I think that's when we first met, when I was up on stage talking about this. It's something I passionately believe in. We can't, as an insurance company and a clinical delivery team, do this on our own. This is a three-legged stool. We need the communities to be a part of this. Like I said, there's information, data, the work that you're already doing day in and day out is so vitally and crucial to the three-legged stool, because without the insights that you're seeing, we're missing things on this other side. And so we both have the collective objective to improve the health and well-being of your residents, our members. And it needs that extra leg of the stool and the insights to really do our best there. We know, as you said, that if we're doing our best, it will yield less visits to the ER, less inpatient admissions, less visits, frankly, to specialists, less drug utilization, because the more we are there side by side partnering with you, and our model actually brings a nurse practitioner bedside and a primary care physician who will work with your teams to then monitor your residents, our members, on a very routine basis. That's how we stay ahead of any exacerbations of care. And they are working at the top of their license so that they know, you know what, you actually don't need to go visit that specialist. We're able to care for you here. We say that we'll bring any care that we can fit through that door. We're going to bring it bedside, because the more we can keep a resident in their bed, in their home, the better, more independent and healthy life that they will live. So there are various, and I talked about this, there are various value-based models in which the senior living communities can participate in. It can range anywhere from quality-based incentives. So for the things that you do that we know are important to that third leg of the stool that you're already doing, holding vaccination clinics, completing those POLST forms, then you get payments for those things, because those are important, critical pieces to the health and well-being. There's a second tier of value-based or sharing in the savings that you're helping to generate, which is then maybe you want to take on some care coordination yourself, and there's a care coordination fee plus that quality bonus. And then I think at the other end of the spectrum, it is then entering into some level of actual direct healthcare to which you will then participate in any savings that's generated. So there are a whole host of different models in which you can then share in some of that.
Okay, so I'm going to ask a question that you may not be comfortable answering, and I certainly would respect that. Can you talk a little bit about what the dollar amounts might be, sort of not obviously not specific, but ranges for those three cares, or is that too specific to the circumstances to do here?
I think it will depend on the needs and circumstances of a community. Obviously, the more volume, meaning the more residents and the more members you put into the program, it's usually like on the low risk end of the spectrum, it's going to be some dollar amount per resident per month.
Right.
So let's just say, I'm giving fictitious numbers here, but it could be something like for every POLST form, you get $5 per member, per resident per month. For letting us know changes in conditions, et cetera. So that's how that end of the spectrum is typically organized, is a per resident per month type of payment for doing certain activities.
Yeah. So as an operator, I might look at that and say, gosh, that's not very much money. But honestly, if you're doing that across 10 or 20 residents, that's another staff person that you can hire that's not going to come out of your bottom line. And so it's actually really, really significant, could be really significant, and just improving the quality of your care, right?
Correct.
And so do you have a sense when if you and I were partnering on my 100-unit assisted living community, sort of ballpark, what percentage of my residents might qualify?
In an assisted living community, I'd say it's a high percentage that typically qualify.
Okay.
And the more density that we can have in one community, the more support and resources we can contribute as well. So for instance, there are communities that we have upwards of 50% of the community in our model. And in those places, we even have an office space or a quote clinic space where we then are on site, where folks can drop in if they need to. So it's an unlimited possibility, the more density and volume that we can put into a model like this.
I mean, the idea of having a clinic on site to me is just mind-boggling, right? I toured an Erickson community in Denver a couple or 3 years ago. I don't know if you're familiar with Erickson. They have these large, typically 1,000 to I think more like 1,500 up residents, more independent assisted and skilled memory care. And they way back cut the deal is not the right word, but they actually got kind of a special, they have their own healthcare plan that apparently is not allowed anymore. And so they've got physicians' offices on site. And I remember walking by one day and there are all these residents just piled in there waiting, and everybody's having a good time. And it's a very social thing because they already know each other. But most importantly, they don't have to leave. And so it just is a win for everybody. I mean, it was clear the residents were happy to be there. And I think that that's a possibility for so many communities. Now,
you've talked about like the burden on staff. Think about when you do have something like that, you don't have to coordinate the appointments, coordinate transportation. Those are all things that are taking away time from the community's staff that would go away.
Well, and I just think, how many times would you have a situation where somebody's fallen and you normally would have to call 911, even though you look at it and say, I don't think they're really needing to go to the hospital, but to be safe. And you go down and you grab the PA or nurse practitioner, and they can come in and do what they need to do and make a decision. And it's better for everybody.
Absolutely. And in addition to, like, say we don't have enough volume for the actual clinic space, this model, our clinical team is actually available 24/7. So we make sure that we'd like to be your first call when there's that feeling, right? If it's a true emergency, absolutely call 911. But if it's something where you're like, goodness, I really don't feel like I need to do this, and I know it's going to mean they're going to get transported to the emergency room, we're your first call.
Well, so I've got a question running on LinkedIn right now. I'm going to do an article on the 10 things that families do that annoy senior living operators. And I just asked operators to give me the things that annoy them. And one of the ones that somebody talked about was the fact that families get upset when the community calls 911 for things they don't think they should call it by. And the comment was, rightly so, was that what the families don't seem to understand is we, the community, don't have a choice. We have to do that. And this gives you another choice. So it's really, really magical. Now, are you, what's your geographic range?
Today, we are in Los Angeles County, Orange County, San Bernardino County, and then Maricopa and Pima counties in Arizona.
Okay. If I'm in Illinois or New York, are there other organizations that are doing this?
I don't know about Illinois in particular, but there are many organizations similar to this that are doing this across the country. So if there is a question, we're always happy to provide alternatives.
Okay, terrific. And the other question I guess I have is, as you described bringing in resources earlier, it sounds a little bit like hospital at home which isn't technically part of the regulations in California, I know. Is that fair?
I mean, the degree of acuity of cases that hospital at home would be caring for, we cannot do that level of acuity.
Okay.
But there are a number of things, as you were mentioning, like this likely doesn't need an emergency room situation. We can handle a number of things that are in that gray zone. And then if it does warrant, like, you know what, I do think we need to take this resident and transport them to an acute facility, we will be a part of that coordination and stay involved in their care so that there is that continuity, which I think is important.
So it does require typically people to change who their primary physician is. Is that probably true?
Correct.
Okay. Okay. So what else should I be asking you about?
Maybe it's not a question, but I'll turn a question back at the group, which is, this is something that I've advocated for and am passionate about. And it's not just because we have this model. Like I mentioned, I had my own mother and mother-in-law in these communities and just saw the exasperation that the staff felt. And I felt like we had the most tremendous caregivers in the communities that were serving both my mothers. And so why has there been so much hesitation, and how can I try to remove any hesitation, fear, so that we can jump into this more? Because every time I feel like I've spoken about this topic, there's interest and I can feel the desire to jump in, but then there's still something that's holding back senior living communities from jumping in.
Okay, I think I can address this question a little bit. So I'm actually glad that's a great topic. I think it feels really confusing. So maybe what would actually be helpful for us to do is to just sort of walk through the process. So I'm a senior living operator. I'm watching this right now. I'm thinking, I just want to do a better job for my residents. And one of the areas that I think we could really help would be to provide better healthcare and be a bigger part of the system. And it feels overwhelming. Where do I start? So what you're really saying is I start by calling scam, right? And then
maybe another suggestion would be, in that call, bring 2 to 3 use cases, live use cases that you struggle with in the community, and let's talk through those. I think it would be best to have applicable examples of how we can then walk you through, here's how it would be different, here's how we can help, and work together to make that less challenging or less burdensome.
Okay, so I'd say, here are some residents who I think might fit. We'd have this discussion about whether they'd be appropriate.
It doesn't have to be specific to the resident, but just maybe a use case. Like, we really struggle with fall prevention. We find that every month we are looking at our emergency room admits based on falls. And as much as we've trained our staff and we've got technology in the room, we're still feeling like these are avoidable things that we haven't been able to tackle.
Okay, so this is super. So I'm looking at this and I'm thinking, I'm just sending too many people to the hospital, or I'm having too many falls, or I've got too many families that are unhappy because we're having medical interventions, or I've got families who are not doing a good job of they've committed to taking their loved one to physician appointments and medical appointments, and they're doing a crummy job on it. And it wastes my time. Those would be the kinds of things that you really, really help with. And do you help with transportation too?
We do. So if this is a SCAN member, we have a transportation benefit. So that is something that's available to our members, and we can coordinate that. Our clinical team can coordinate.
Okay, so I know I'm gonna dig into the details a little bit, but I think this will be helpful to a lot of people. So you and I, we have this conversation, and I go, okay, Let's figure out, let's go do it. What happens next?
So then we'd say, okay, there is a there. We see how you can help. We would then talk through that range of different contractual arrangements, like how much do you want to be involved? If it's just that you want to bring in our clinical team and you don't want to be involved because you just want to see how it works, we can start there. We can then bring our sales team to do some educational sessions in the community with the residents. We can bring our clinical staff to do meet and greets. They can do maybe even some fall prevention type of sessions. So it could be a more soft introduction and then see what interest we gain as we start enrolling folks. Then you have the ability to work with us and see how the interaction kind of flows. If you want to jump then into the next phase of, hey, we really like this. Now we want to be a part of it because we are doing some of the work. We see we're contributing to the wonderful outcomes. Then let's talk about that quality-based incentive. And we then can curate the list of different things that leverages what you're already doing, and we can make sure that there's a payment for that. When I mentioned the $5 PMPM, which may not sound like a ton, it's usually a list of like 10, 15 different things that when you collectively add that all up, it then becomes a much more sizable number.
Yeah. So, and is there a sort of a minimum number of residents you have to start with?
We'd love it to start with 100% of the.
Of course you would. Of course.
No, we understand that we've got to work to build the trust and for folks to understand who we are, because it is that change of primary care physician. So we start with member one and we build from there. And usually we find that then there is a word of mouth that sort of starts, and it's like, I want what you've got. How are you getting that much attention?
Yeah, I mean, I'm just thinking, right? I hear about somebody who had, I'm a family member, and I hear that my mom's friend fell and didn't have to go to a hospital, and my mom had to go to the hospital for a very similar fall because I didn't do this. That becomes super compelling, right? So I really like that. So one more question, because I'm totally obsessed with this. I can't believe I haven't asked before. As you heard me talk about, as in the intro, we have announced this, the Foresight AI Lab, where we're going to do a deep dive into AI in senior living. And we see it a number of places. We see it in terms of better resident care, healthcare. We see it in dining services. We see it in the HR, staffing, life enrichment, those kinds of things. So I got to ask, what are you guys doing with AI in SCAN to make things better?
Right now, we're dipping our toe in the water with AI, more from a work process and information gathering sense. So an example being that we're using AI to kind of cull and sift through our call notes, the calls that we get. What are some of the themes that we're seeing? We can do that, and we've been doing it, but I think AI has elevated our ability to see different themes that maybe a human brain wouldn't have strung together to say, hey, there's a theme and trend here, and maybe pay attention to why folks are calling in, because we view every call into our system as something that isn't getting taken care of somewhere upstream. So really using AI more from a information and insights perspective, and then work process efficiency.
So I think that's one of the, I sort of have this vision. It's not there, I don't think, but I have this vision of everybody who has resident interaction working with, sort of what is a Star Wars tricorder thing that sits on their shirt, right? And as they're going in, they're having these interactions, and it's quietly listening in and just extracting data. And so it starts to develop these patterns, and you can look at that and say, well, man, you're only spending an extra 2 minutes a day with this resident, and you probably haven't even noticed that it's longer, but the data tells us that you're spending 2 minutes longer there. And on one hand, you might look at economically and say, well, that means a different care level, but maybe even more important than that, it would suggest that maybe things are slowing down for that resident, and there are some interventions that you can do. And so that's the stuff that just gets my juices flowing.
Absolutely. And that's where I'm saying those are the kinds of things we would never be able to see from the physician office interaction or a health plan perspective. So I love that you're going down that path, because that's going to only enhance the care that we can provide collectively.
Yeah. So anyway, we are, Karen, this is so exciting. I just, I know in the industry, in the world of senior living right now, we have this, we don't have enough docs. And my generation of boomers, we are all getting older and we're spending more time on medical care, and it's putting pressure on the system, and it's only going to get worse. And what you're doing, what other people are doing, what AI can do will, I don't know that it's the ultimate solution, and there's probably no one ultimate solution, but this is a huge, huge part. You guys should be talking to Karen and her organization. It'll change how you deliver care to your residents. And so, Karen, this has been great. I appreciate you joining us. If you can hold on for just a second, thank you all for watching. Don't forget to sign up for our email and watch for more news on the Foresight AI Labs next week. We think we're going to have tickets for sale, and they will go fast. Karen, thank you very much. Any last word for me, by the way?
No, just thank you so much for having us on. And please, to the listening audience out there, do give us a call.
Absolutely. Thank you very much.